The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, everyone. Glad to see you. Happy you're here. We are gathered for the next episode of TMD Demystified. My name is Tony Urbanek. Today's episode is entitled, Why Not Use Common Sense and a Few Facts to Treat TMD? Why not use a little common sense on treating TMD rather than doing things like just treating symptoms and using things that traditionally knowingly don't work, like night guards? We've talked about that so long. But I just want to make a few points here about really when you take the broad view of this problem and the research that I've done, it really turns out that the solution was connecting a few dots and using common sense about doing the research on it and then developing a very simple solution. I have discussed this story in the past in various episodes, but I wanted to bring it together in a concise fashion today. So it might be a little more meaningful to be more concise. Maybe it will even shorten this podcast and you won't have to listen to me as long. But when I decided 14 years ago, as a practicing oral and maxillofacial surgeon who had done 2,000 temporomandibular joint surgical cases to attempt to correct the problem with mixed results, the results were reasonably good. 2/3 of the patients did okay, well, but a third of the patients would be back no matter what kind of surgery I did for them. They would be back within a year or two with similar symptoms, which led me to decide not to do any more temporomandibular joint surgery and to go off on a tangent and a track to see if I could figure out, discover really what was happening with this problem that everybody called TMJ, more appropriately called temporomandibular joint disorder. So I started at the beginning. Again, a little common sense. If you know what you have been doing is not effective or ineffective at least a third of the time, you would want to start out at the beginning and quit doing what you were doing before. And what I was doing before was listening to my colleagues, listening to what my colleagues wrote on textbooks and journals and presented in meetings as to what to do surgically for the problem. And I was also aware and schooled into what my non-surgical colleagues in the dental field were trying to do to treat TMJ problems, TMD non-surgical, and their results were even worse than the surgical results. And the most common one to this very day is 50% of the dentists prescribe a night guard to treat temporomandibular joint disease, which actually makes no sense at all. It makes no sense. A night guard is a device, it's a good device to protect the surfaces of the teeth, keeps you from cracking, damaging your teeth if you are a bruxer. But bruxing is only one of the causes of TMD. So, I mean, even if a night guard worked, you'd only be addressing one of the causes, one of the three. So, but a night guard doesn't do anything other than protect the teeth. It has nothing to do with stopping people from clenching or grinding their teeth. In most cases, it even makes the clenching and grinding worse, and that is by documented survey from thousands of patients. All right. So that is just some of the stuff. Some of the nonsense has been done for the past 70 years by the general dental colleagues and including my oral and maxillofacial surgery colleagues who, do surgery, then things that may be effective only 2/3 of the time. So 14 years ago, I decided to see if I could do the research and solve this problem. And where do you start when you do research from whole cloth and eliminate all prior biases, both surgical and non-surgical biases, medical biases, take all the biases away? Where would you start to do research? You start with the patient. And that's exactly what I did. And as it turns out, the patients actually, in a very short period of time, directed me where to look. They did not give me the solution, but they actually gave me the simple information as to where to look, to begin to look for the explanation of how you can have many disparate symptoms, and the symptoms are very disparate, from headache to earache to jaw pain to neck pain to shoulder pain to ringing in your ears, fullness in your ears, dizziness. These are really disparate symptoms. And how do you get all and well established, well agreed upon symptoms by everyone? Those are symptoms of TMD, a locking of the joint. One of the common feels like a toothache. I mean, these are really, really strange, disparate symptoms, but they're all known, associated with people who have problems with their temporomandibular joint. So starting with the patient, I began to interview patients, actually roughly 24 patients, and instead of telling them what kind of surgery I was going to do for them, for their symptoms, I just sat down with them and said, tell me all about it. What do you think about it? What makes it better? What makes it worse? What does your husband say about it? What phase of the moon is it when it hurts? Tell me all about all of the symptoms. Tell me everything you want to tell me about your symptoms. Tell me what time of day it hurts. Is it at night? Is it in the morning? And I heard a lot of stuff that I was aware of, I had heard before, but I heard one thing that I had never heard before after interviewing 24 women, each of them for anywhere between 15 and 45 minutes. Half of them said something like, if I take my finger or a pencil eraser or a piece of cloth or a piece of rubber and gently put it between my front teeth and gently bite down, it feels better. The symptoms somehow feel better. So with that in mind, I made a very simple device that did nothing more, nothing less than situated between the front teeth and a device that they could talk with, that they could sleep with, that they could breathe with. You just can't chew with something between your front teeth. And I had a lot of experience making oral devices for cleft lip, cleft palate patients, for trauma patients in reconstructing trauma to the face that I did for fully 50 years. Making facial reconstruction, skeletal reconstruction, oral devices that patients could speak with when necessary. So I made a device that they could speak with that separated the back teeth, only the front teeth touched. And to my surprise, and the patient's surprise, we were both surprised that on the first issue of this, 100% of the patients, 100% of the first patient's symptoms were gone within 3 weeks. Now, those statistics do not hold true for every patient. We now know that doing the protocol and using the device, the average is 70% symptoms relief, decrease over the first 3 weeks. But you can't chew with this thing in your mouth. But after roughly doing another 40 or so cases with similar results, with the patients saying anywhere between 50 and 100% of their symptoms were diminished or gone within just a few weeks, I was stumped. I had no idea. I had no idea how this worked, but I had to figure it out. And that really wasn't the hard, that wasn't the hard part. The hard part was to get rid of all the prior biases that are in the literature, that are in the congresses, that my colleagues speak on at meetings. Get rid of the biases and just start with the patient. And they said, if I put my finger, my tongue, a pencil eraser between my front teeth, it feels better. And it did. It created a huge difference. And it went on. We worked out the protocol. Protocol worked out to be 24/7 for 2 months, then nighttime only the rest of your life. And the device is very simple, but that's not, not going to spend any time talking about the device. All it does is separate the back teeth according to a protocol that you follow 24/7 for 2 months. Take it out to eat. After you eat, you brush your teeth, you put it back in. You can speak with it. And then nighttime, sleep time. Most people, I assume, sleep at night, but sleep during the day, put it in. And the results are spectacular and proven statistically in a independent study based on 3,000 successfully treated patients. But again, back to the point, common sense. So the first common point of common sense was get rid of all your bias and go back to the patient and start from the beginning. Start from the beginning, start with the symptoms, which are these disparate number of symptoms, and let the patient say what is going on with the disease. And in this case, they led me to the direction I needed to look, which was unload the temporomandibular joint. So point one of the actual discovery, there were 3 pieces of literal common sense that led to the discovery of what was going on. How can you create all of these disparate symptoms out of one joint up here in your head? So once I decided that what you were doing is nothing more, nothing less than separating the posterior teeth, because the anterior teeth do not allow but 10% of the loads on this joint. Point number 1, common sense, well known to the dental community, and that is these joints are loaded by function on the posterior teeth. 90% of the loads on the temporomandibular joint are from the posterior teeth. The anterior teeth do not allow but 10% of the loads. That's why you crack nuts with your back teeth. You don't do it with your front teeth. That is common knowledge, and statistically proven knowledge in dentistry and taught in every dental school, that point. So the second point is I discovered, but it wasn't an independent discovery, every oral and maxillofacial surgeon who has ever operated on the temporomandibular joint has found that when he sends a piece of tissue to the pathologist associated with that surgical procedure that he performed, and it is standard operating procedure for a surgeon to send to the pathologist tissue if he is doing surgery. And I found that after 2,000 temporomandibular joint surgical cases, 100% of my cases would return from the pathologist as line number 1 on the pathology report, chronic inflammation, whether it said verbatim in quotes chronic inflammation or it described the cell types that are associated with chronic inflammation, either or, specific or general. The first line of a pathology report after 2,000 and including each and every 2,000 cases that there was chronic inflammation within the temporomandibular joint. So I had to assume, and you should assume, that if you have temporomandibular joint problems, TMD, there's chronic inflammation in the joint. It really stands to reason, and again, looking back through the retrospective scope, looking at why and how this wasn't pursued earlier and pursued before, I am surprised, because every surgeon, every doctor, every dentist is well familiar with how effective non-steroidal anti-inflammatories are. The most common non-steroidal anti-inflammatories are ibuprofen, and aspirin. They are anti-inflammatories, non-steroidal anti-inflammatories, and they are extremely effective on treating symptoms of TMD, but only for a short period of time. And everyone knows that. If you use them consistently, daily, they will run out of steam within a week or two, at which you can take all you want, but they're not going to be as effective as they were on day one. The effectiveness will strategically decrease. But what are you doing with a non-steroidal anti-inflammatory? You're decreasing inflammation. So it would stand to reason that if a simple drug like non-steroidals would help the problem, decrease the symptoms, why not figure out a way to bolster, increase, improve the reaction, any kind of reaction, to decrease the inflammation? Now, you could use drugs. Stronger drugs have stronger side effects, and that has been attempted. And the stronger anti-inflammatories you use, you end up with significant, one in particular ending up with cardiac problems by using a very, 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 very strong anti-inflammatory. However, it stands to reason, common sense again, that if you have a joint that is giving you trouble, why not just unload the joint? Now, common sense. If you have a knee problem, your knee is painful, you go to the orthopedic surgeon, and the orthopedic surgeon will do his extensive workup, and more than likely he will say, oh, you've really damaged your joint. We're going to need to do some surgery on this joint. And if you say, no, I don't want to do any surgery on my joint, what else can you do? Well, nowadays he'd say, well, we'll inject the joint with steroids and related drugs for a year or two, and then we'll do the surgery, at which point the patient may say, I don't want to do injections and then surgery. What else can I do? Well, at that point, the orthopedic surgeon would hand you a set of crutches, and rightfully so, tell you that if you get on these crutches and stay on the crutches, your knee pain will go away. And he would be correct 100% of the time. And what is he doing when he does that? When you go on crutches, you stop loading the joint, you unload the joint, the knee, and the inflammation will die down, and the symptoms will go away. Common sense. Common sense. This same procedure, the same solution applies to the temporomandibular joint. Now, the dentists have been taught in every dental school in the United States of America, and probably the world, but at least in the United States, I am absolutely certain that they are taught this joint is different. That's why they didn't even think about comparing this joint to the knee. But the truth is, from my viewpoint, is not only a dentist and MD physician with a degree in cell biology and anatomy, this joint operates like any other joint in the body. And so what is taught in dental school at this joint is different. It's complicated what the doctors are taught. It's complicated. It's not complicated. It operates like any other joint in the body under the same principles. And if you start from that position, then you can figure it out. So we've established 2 points already. The first point is 90% of the loads on this joint come from the posterior teeth. So what you're doing is unloading the temporomandibular joint. The second point is that the common denominator of the symptoms of temporomandibular joint problems is chronic inflammation. And then finally, the third point, which was well known and established by my orthopedic surgical colleagues 50 or more years ago, and that is when you have inflammation in a joint, in any joint, in a knee, a hip, and especially the elbow, signals are sent to the brain, specifically the brain stem, the lower parts of the brain stem, where you have no cognition, you do not have awareness of what's going on, but signals are sent to the brainstem that announces that the joint in question is inflamed. And the signal comes back down from the brain, don't move the joint. Don't move that joint. And causes the muscles that move the joint to tighten up, and wherever those muscles are attached to the bone is where the muscles get tight and they pull on the bone, and that's where it hurts. That is common knowledge within orthopedic surgeons, and it applies, as I was told, and that's the third part of the piece of the puzzle, a little bit of common sense, with starting with this joint isn't different than any other joint in the body. It operates like any other orthopedic joint in the body, but the dentists don't think of it that way. But when you do think of it that way, you can understand that tennis elbow, which is nothing more than inflammation of the lateral epicondyle, of too much repetition of the forearm, and patients don't complain of pain in the elbow, they complain of pain in the forearm where the muscles get the purpose to tighten up. They get the signal to tighten up, pull on the bone, and the patients complain of forearm pain and pain all the way into the wrist. Very unusual for a joint problem to cause wrist pain or forearm pain. But that is what tennis elbow is all about. And the way you treat tennis elbow is to put the arm in a sling and don't move the forearm for a while, and the inflammation will go away. You're basically unloading the elbow. You're unloading the lateral epicondyle. Just like you unload the knee with a set of crutches, and just like you unload the temporomandibular joint with a device that unloads the joint by disoccluding the posterior teeth. That is the solution. And all it took was a little bit of common sense and a few technical facts, and connecting those dots, connecting each one of those dots, driven by basic information originating from the patient. If I put my finger, my tongue, a pencil eraser between my front teeth, it feels better. Well, why does it feel better? Well, we figured that out because you're disoccluding, separating your posterior teeth, you're unloading the joint, allowing the inflammation to go down, and you have to do it according to a protocol which allows the inflammation to go down consistently, relatively rapidly, and over a long period of time. That is the nighttime only for the rest of your life, part of the protocol. It's not complicated. It is not complicated. So that's what I have to say about this problem that everyone calls TMJ, temporomandibular joint. You call it TMJ, it's like going to the orthopedic surgeon and announcing you have knees. And the general dentists are still taught in dental schools and still operate from the viewpoint that if you make a night guard and give it to the patient, you're treating their TMD problems. And all you're doing with a night guard is giving them something else to chew on between their posterior teeth. That's why a night guard doesn't work. But 50% of the dentists still use night guards and prescribe night guards. And 50% of the dentists don't want anything to do with treating TMD because they know this joint is complicated. They were taught that in dental school. They were taught it's complicated. It has a complicated name, gangliomo-arthrodial joint, so it must be complicated. And then they go on and turn the patients away. That is the state of art, if you want to call it that, of dental and medical practice in the United States of America in 2025. But I just gave you the track that I followed in doing this research. And in my mind, it really wasn't complicated. Knowing a few bits and pieces, a few facts about anatomy, about neurology, about physiology, about dentistry, about teeth, and especially about joints. The TMJ is just like any other joint in the body. With that said, I appreciate your attendance. I hope that this presentation was helpful to you, that gives you a new viewpoint, whether you are a patient, which I know a lot of patients, people with this problem watch these podcasts that I produce in these episodes, and especially if you are a dentist who doesn't know what to do about TMD problems. You are welcome to find out more and join our team of doctors throughout the United States who use this device and protocol to treat TMD very simply, very effectively, and you're welcome to contact us. I can be reached personally at tony@tmjservices.net, tony@tmjservices.net. And if you would like to talk with me or even criticize, make sure you bring your statistical information, your proof to discuss it. I'm happy to listen. I'm happy to be criticized. And if you'd like to join our team, you can do that by going to our website, www.urbanektmj.com, urbanektmj.com. With that said, I look forward to our next episode, which will be in a week. I am Tony Urbanek, and this is TMD Demystified.